Well, Dr. Ludwig, thank you very much for joining us for this discussion today. As we kick things off, could you just start off by giving us a brief overview of your clinical experience in your practice at the University of Maryland?
Sure, and thanks for having me, Matt. I really appreciate the opportunity. So I've been at University of Maryland for the past 18 years, and my practice has clearly morphed over the past 18 years. I'm an orthopedically trained spine fellowship surgeon. When you look at my practice, about 75% of my practice is elective spine surgery. Most of the spine surgeons treat degenerative thoracolumbar and cervical. Mine sort of emulates that as well. I do a lot of revision work as part of a more tertiary quaternary referral center, and a lot of adult spinal deformity. About 25% of my practice represents traumatic spinal cord injuries because of University of Maryland's affiliation with one of the busiest level 1 trauma centers in the world, Shock Trauma Center. So I'm privileged to work there because it brings very exciting cases to sort of my doorstep and adds to the bandwidth of my practice. University of Maryland is a tertiary referral center, but yet has a bunch of sister hospitals where I also do some spine surgery as well. So my experiences are not only at a big academic university-based hospital or a level 1 trauma center, but I also do spine surgery out in our community as well. When you look at how my practice has morphed over the past 18 years, I've been trained, like most other surgeons from my generation, as an open, spine surgeon. And with the evolution of minimally invasive surgical techniques, I've approached certain patient problems and disorders from a surgical perspective through minimally invasive techniques. But because of the diversity of my practice, my interest in minimally invasive surgery has morphed towards more complex adult spinal deformity, trauma, tumor reconstruction, and infection, but also employ it for more degenerative techniques that most other folks implement those techniques as well.
Great, thank you. That context really helpful. And you talked about how your practice, Dr. Ludwig, has morphed from training through the course of your 18 years at the University of Maryland. And if we can, for the audience, maybe just a quick summary of your background in training, well-known institutions that I think will provide some context as we discuss further how exactly you considered the evolution of different techniques and procedures in your practice.
Sure. So my residency in orthopedics was at Thomas Jefferson University Hospital. A lot of people know it as the Rothman Institute. So I spent a lot of quality years there where my mentors influenced me into a career in spine surgery. Following my residency at Jefferson, I went on to do a spine fellowship at Emory, where I sort of furthered my interest in spine surgery. And it was interesting when I finished my fellowship in the early 2000s, the minimally invasive spine surgery was really in its infancy, right? So I was trained once again as an open surgeon, and a lot of the techniques, most like everybody, how they went through their training, people and surgeons do things a lot differently, 5, 10, 15 plus years out of their training. But I owe it to all my mentors that trained me in terms of sort of the philosophy that sort of was instilled into me and that I instill into our residents and our fellows that we train now. I think at the end of the day, my mentors, Alex Vaccaro, Todd Albert, John Heller, Scott Bowden, I'm not going to name them all, but those are some of the key pivotal docs during my training, always taught me that spine surgery was really a very discretionary type of specialty, right? I think it becomes obvious if somebody has a traumatic injury of the spine and they need to be stabilized. It becomes obvious when somebody has an evolving neurologic deficit and is losing function. It becomes obvious when to operate when somebody has a tumor, right, that has intractable pain and losing function, right? But for more of these discretionary type of elective procedures, selecting the proper patient is paramount to having successful practice, and really having happy patients, right? That brings more patients to you and having a really great career. So I think overall, Jerry Kotler was a doc from Jefferson that instilled into me that the decision to operate was always more important than the incision, right? And it's people like that from a philosophical standpoint, really were helpful in deciding, once again, selecting the proper patients, and then most importantly, selecting the proper technique, right? I think when we look at patients, at least when I look at patients, I look at them and I try to establish what my goals are for that patient, right? Do I need to decompress them? Do I need to stabilize them? Do I need to fuse them? Do I need to realign them? Whatever those goals are. And then we determine how to accomplish those goals and what's the safest way to accomplish those goals, right? What's the least morbid way? Is it an open fashion? Is it minimally invasive? Is there a hybrid approach? I think over the past, once again, 18 years, my philosophy and my decision to operate and my selection criteria and my goals really haven't changed, but how to accomplish those goals and the new sort of techniques that have evolved and that are in my armamentarium have changed and have effectively changed the way, I do procedures today.
No, I think that that perspective is great, Dr. Ludwig, and there's really a lot to unpack in what you just said. So I want to try to piece some of this out as we move forward here. You talked about in your training early, really being at the infancy of the introduction of minimally invasive or less invasive techniques in spine surgery. You talked about your mentors and the sort of emphasis on patient selection and selection of procedural intervention. And given that you're an orthopedically trained surgeon, you come from a specialty that has well-established criteria and standard of care around general orthopedic procedures, yet spine as a subspecialty, sort of sits on the outside by comparison in many ways. And I think that also includes the adoption of minimally invasive techniques or the evolution towards minimally invasive techniques from a procedural standpoint, which we've seen broadly adopted in orthopedics and other musculoskeletal approaches. So with that context, how have you thought about the role of open versus MIS surgery and sort of the pros and cons as you've started to evolve their use in your practice over the last 18 years?
Sure. So, my philosophy with regards to choosing a procedure, whether or not it's open versus MIS, is that my goals never change, right? I always want to maintain the goals of decompression, stabilization, fusion, right? But if I can do that in a least invasive fashion with less collateral damage to the muscles and improve on a patient's care moving forward, both short-term and even long-term, that would be great, right? I think the debate, it's really not a debate about open versus MIS in my mind. It's whether or not you can achieve the same goals, because your goals should never change. I think what minimally invasive spine surgery has allowed us to become are actually better clinicians, right? we try to scrutinize what a patient's pain generator is, right? And then we could scrutinize exactly how to take care of that pain generator, whether or not it's a open or minimally invasive foraminotomy, whether or not it's an open or minimally invasive TLIF or a lateral-based approach, whether or not it's a deformity correction or not, or whether or not you only need to treat a component of the deformity as opposed to performing a very large deformity-based procedure. Adult spinal deformity are some of the largest surgical procedures that are known to mankind, if you think about it. And we all know that these larger procedures and more complex procedures come with a lot of complex problems and complications. And sometimes you have to treat the entire deformity, and sometimes you can be fairly selective and more minimalistic or perform a hybrid approach. So for instance, maybe in somebody with a very major adult spinal deformity, they don't need a large open osteotomy with a T10 to pelvic reconstruction, infusion, all the morbidity associated with that. Maybe they just need their fractional curve fixed through a minimally invasive TLIF. Or if you can deconstruct it down to a specific nerve root in the apical region of the curve, maybe you need a lateral-based approach, right? The question that I always raise in my mind is, what's the durability of those smaller procedures, right? We're always weighing, at least in my mind, the pros and cons of the durability of a minimally invasive procedure versus the surgical morbidity of a much larger reconstructive procedure.
I love the sort of characterization and focus of one part of your answer there, Dr. Ludwig, which really talked about never losing sight of the surgical goals and then determining how you can achieve those goals in the least morbid manner possible, which I think is should be the goal of any surgery. As you think about how you've trained on, learned, and adopted less invasive techniques into your practice and sort of the learning curve that's inevitably associated with that. And I guess also given the fact that you work daily with residents and fellows who you're training, as well as a faculty member in courses around the globe, how would you counsel other surgeons either earlier in their career or maybe even further into their practice who are beginning to evaluate less invasive techniques to be successful in how they incorporate those into their practice while not compromising their surgical goals and patient outcomes?
Yeah, that's a great question, Matt. And safety is always at the top sort of the totem pole as well, right? We want to do something that's least invasive to achieve our goals, but we want to make sure it's safe for our patients as well, right? And I think you have to know what your goals are, and you have to understand as well as your surgical abilities and where you are. You brought up learning curves, right? There are certain minimally invasive procedures that have a very short and steep learning curve, right? And that means that there's going to be a lot of experts around. And then there are certain minimally invasive techniques that have a long, flat learning curve. That means that there are few experts around, and it's going to take much longer to accomplish, those goals once you have, your learning curve sort of mastered. If it's more of a challenging technique, I think what I counsel our residents and our fellows as they leave our program and go out to the world, I never allow our fellows to start doing minimally invasive techniques until they've mastered the open anatomy. So when you come through, and a lot of programs mirror the philosophy that I've just talked about, right? Before you do a minimally invasive TLIF, I think you really need to understand how to do an open TLIF. Before you do a major sort of fracture dislocation through minimally invasive techniques, thoracolumbar techniques, you really need to understand how to treat that fracture dislocation through an open fashion. So I think both take a considerable amount of expertise and time to do. So your first MIS TLIF or your first multi-level fixation for a fracture dislocation is going to be much more challenging compared to your 10th one or 15th one. But I think once you've gone through the learning curve, you're comfortable, perhaps you're using enabling technology, computer-assisted spine surgical devices, robotic technology, right? All of those can be helpful early onset in your learning curve. I think you need to counsel your OR staff. I think you need to let your patients know they may be in the operating room a little bit longer, but yet hopefully the benefits of these techniques will play out in the long term. I think it's important when you're doing these minimally invasive techniques that you don't tackle these very challenging problems at first, right? It's almost like skiing. You're not going to go down an expert trail first before you go down the bunny hill, right? You're going to make small steps, hopefully in a positive direction, before you try the more challenging cases or slopes, right? So doing a laminoforaminotomy, and then maybe that merges into a one-level TLIF for a degenerative spondylolisthesis, doing percutaneous fixation for an unstable burst fracture, doing a lateral-based approach, maybe in somebody at the L2, 3, or 3, 4 level, right, which is an easier level to navigate through, as opposed to doing somebody with a multi-level lateral TLIFs for a T10 to pelvis percutaneous fixation or a fracture dislocation, right, that you have to do minimally invasive techniques, fracture reduction techniques through minimally invasive options, and multi-level percutaneous fixation, stabilization. So once again, I think if you start with simpler, more basic types of cases, you can advance your learning curve more effectively for those larger cases. And you have to understand your techniques, use enabling technology, and let everybody in the operating room know what your expectations are for the case as well.
We had an opportunity to catch up a few weeks ago, and you had shared some of the impact to your practice as a result of COVID over the last several months. And one of the things that you had shared is, not unlike your colleagues around the globe, you had a little more time on your hands than you normally do due to the suspension of scheduled and elective surgeries. And you had an opportunity to evaluate some of the characteristics of your practice and your case mix and the use of, more traditional open and maybe some of the less invasive techniques. I'd love to hear your perspective on sort of what your thinking was yourself in collaboration with your residents and fellows or your colleagues, and maybe even a specific example of how you're starting to shift some of your thinking around, not the patient selection piece, but the procedural indication for less invasive techniques as you continue to evolve the use of these procedures in your practice.
Yeah, that's another great question, Matt. So COVID clearly has changed our practices, much like everybody who's going to be listening to this podcast. What COVID has done is it's made us take 2 steps back and think about the care of a patient really from start to finish. And when I say from start to finish, really one of the more minimalistic ways of evaluating and triaging patients starts in the clinic. And how have we minimized this? Well, one form of minimizing exposure to our patients is through telemedicine visits, right? So we are vetting patients out initially through telemedicine visits and minimizing their exposure to clinics and to others and their throughput in our clinics by just bringing them in if they meet surgical criteria, right? And OR time is precious, as you intimated. Resources are precious, meaning PPE, not only PPE, but ICU, stays, and resources in the hospital are scarce, right? And really, our ability to dispo a patient or get them to a rehab facility is really challenged. And the last thing somebody who has a semi-urgent or urgent, or even nowadays that the elective base is starting to open up, those patients want to do is they don't want to go to a rehab setting, which exposes them once again to COVID issues, but we want to get them home, right? And because those resources are so precious, and because we want to get our patients home, and we want to avoid having patients return to the ER with problems, we want to avoid having them readmitted, right? We take 2 steps back, and after we evaluate them, we say, well, what are our goals for this patient, right? Do they have a facet cyst at L4-5 with a horrible L5 radiculopathy that needs their facet joint taken out, low-grade spondylolisthesis, and a single-level fusion, right? Somebody with intractable pain that has failed conservative management, somebody that may be neurologically intact, but needs to go to the emergency room for pain control, right? How do we take care of those patients? And once again, using the criteria we just talked about previously, in addition to the COVID concerns, can we do this in a less invasive fashion? So that patient that I just described, at least in my mind, is a perfect candidate for an MIST lift, where you can go in a less invasive fashion, take the facet joint down, take out the facet cyst, and then perform a concomitant instrumentation infusion through a less invasive fashion. We do those types of approaches at University of Maryland with a 1-day stay and get them home the next day. Additionally, patients that I recently had with a horrible adjacent segment disease at the L3-4 level with a severe quadriceps, not a palsy, but severe weakness secondary to pain that just couldn't move. Once again, this is somebody that I had been following for quite some time and then just had it. And this woman shows up. Once again, I get a call from the ED because she can't control her pain. Once again, with the same tenets of preserving resources, avoiding readmissions, avoiding morbidity with a bad adjacent segment disease problem, right? My choice is at least maybe a direct decompression, instrumentation, infusion with blood loss, length of stay, at least in my hands and at my hospital, about 3 days, with the potential need to go to a rehab setting, versus a lateral-based approach, indirect decompression, stabilization in a woman with a normal bone density, luckily, that we can achieve the same goals of decompression indirectly as opposed to directly, less blood loss, less invasiveness. That patient goes home in 9 hours. So clearly, those are 2 examples, at least, that I've had over the past probably 4 to 6 weeks, where less invasive surgery truly wins, right? It's better for the patients, it's better for the institution, and it's better from an overall generalized delivery of care perspective.
I think those are both fantastic examples. Thank you for sharing those. And I guess maybe last to kind of wrap things up here is, I mentioned earlier that we've seen across other surgical specialties, including orthopedics, where minimally invasive techniques have really become the standard of care, and we're relatively far away from that in spine, and for a lot of good reasons, many of which you've touched on earlier. In your mind and in your practice, what are the continued barriers to further MIS adoption or the incorporation of less invasive techniques? And are there specific technological advancements that you think are key to continue to move us sort of down this paradigm shift towards less invasive techniques and reducing overall morbidity of spine surgery?
Yeah, another great question. I think part of the adoption, Matt, is due to training programs, right? My generation of spine surgeons did not grow up with these techniques, right? We had to teach ourselves, right? And I think with the evolution of the minimally invasive techniques, there's somewhat of a slow adoption, right? Not everybody adopts to it, but there's a relatively slow adoption of surgeons from my generation. However, the surgeons that we're training now that are seeing both approaches, both the quote-unquote traditional approach and the minimally invasive approach, right? The training programs are so much better today than they were 10, 15, et cetera, years ago, right? So the exposure is a lot better, right? The fundamental knowledge, right? The evidence is much better. You already said today, it's part of the standard of care. I just want to remind you and everybody that the standard of care is a spectrum, right? That doesn't necessarily mean it's the only way to do a procedure. As we talked about, there's a spectrum of different options that we can do to a patient that are within the standard of care to accomplish our goals. But I think most of the training programs today will teach the fundamentals, right? And the fundamentals in a solid practice enables the outgoing fellows and the more junior attending level surgeons to sort of grow on those skills. And as those skills grow and become more comfortable, I think they'll begin to use those techniques more expeditiously in a safer fashion, as well as for more complex spinal deformity problems, in addition to trauma, tumor reconstruction, and just understanding that minimally invasive techniques is more of a philosophy, right? Once again, if we could achieve the same goals with less destruction to the soft tissues and less collateral damages, then the whole thought of an awareness of the thought that those options exist, I think, are part of the rise in the adoption of these techniques. I think, and I sort of discussed it very briefly, but robotics, I think, will be helpful, moving forward. And currently, different computer-assisted image-guided surgical systems, virtual reality, all of those enabling technologies will expedite and hasten the learning curve and make it sort of more exponential as opposed to more horizontal. So I think there is going to be a rise. These techniques are not going away. I think they will only grow. I think the question is how rapidly they will grow.
Well, Dr. Ludwig, thank you very much for your time. You've been extraordinarily generous. It's been great to chat with you and get your perspective. And we'll certainly look forward to following up for further discussion at another time. So thank you very much.
Great, and thanks for having me. Appreciate it.